And so this is the last group of OB anesthesia topics that we're going to discuss for keywords. And we're going to focus primarily on some big issues: preeclampsia, obstetric hemorrhage, cardiac disease, and pregnancy. So again, I'm going to be going through this very quickly, but if you do have questions, please let me know. So let's start out with, you have an otherwise healthy woman at 33 weeks gestation who's now been diagnosed with severe preeclampsia. Which of the following is most likely a sign she has compromised renal function due to her preeclampsia? So the answer would be A, a serum creatinine of 1.1, which we think of as in normal range, but as we talked about during our physiologic changes of pregnancy last week, a normal creatinine in a pregnant woman, because of increased GFR, is going to be about 0.5 to 0.6. So she's had almost a doubling of her creatinine. So in terms of definitions, we refer to this overview of the hypertensive disorders of pregnancy. And that will include both gestational hypertension and preeclampsia. So gestational hypertension is essentially a woman that has hypertension, systolic over 140, diastolic 90, that develops after 20 weeks gestation. So she did not have pre-existing chronic hypertension, but has that gestational hypertension without any proteinuria or any severe features. So that is the diagnosis of gestational hypertension. Then you get to preeclampsia. So preeclampsia, and now we only use the terms preeclampsia or preeclampsia with severe features. Until a few years ago, we also referred to the term mild preeclampsia. So preeclampsia, just in general, is the hypertension along with proteinuria, which is either defined by doing a 24-hour urine where you have over 300 milligrams in 24 hours, or you can do a urine protein to creatinine ratio, and if that's greater than or equal to 0.3, that gives you the diagnosis of preeclampsia. Or you can have the diagnosis of preeclampsia without proteinuria as long as you have any of the other things that are listed here, thrombocytopenia, elevated liver transaminases, the serum creatinine, if they develop symptoms like pulmonary edema or visual or cerebral symptoms, that will give you the diagnosis of preeclampsia. And then going on to preeclampsia with severe features, it's primarily those features I just showed you that you can make the diagnosis of preeclampsia without proteinuria, but adding on that you have a significantly elevated blood pressure with systolics of greater than or equal to 160 and diastolics greater than or equal to 110, and that has to be while the patient's at bed rest, so it can't be after she just walked up 2 flights of stairs to get to her OB appointment, and you have to have at least 2 of those readings that have been at least 4 hours apart. So those are the definitions related to hypertensive disorders of pregnancy. Also, eclampsia is essentially preeclampsia along with seizures, and then HELP syndrome, which is considered a subcategory of severe preeclampsia, includes hemolysis, elevated liver enzymes, low platelets. So those are the diagnoses, the different sorts of gestational hypertensive disorders. So in terms of the pathophysiology, it's really not well known, but we know that it involves endothelial damage to within the placenta is the underlying etiology somehow, and that endothelial damage results in the release of placental vasopressor activating substances such as endothelin. And essentially, preeclampsia is a disease of vasoconstriction that can involve any organ system within the body. We also know that there is a change in the thromboxane to prostacyclin ratio, that's increased, which also promotes the arterial or vasoconstriction, as well as platelet aggregation that you can see with pregnancy, with preeclampsia. And as I mentioned, endothelin levels have been shown to be increased in these patients, and that also contributes to vasoconstriction. So how does this affect us when we're taking care of these patients? So we need to understand how any organ system can be affected. Not every organ system is going to be affected in every patient. Different organ systems will be affected in various patients. So major concern for us as anesthesiologists is the airway. You can have airway edema. Edema used to be part of the definition of preeclampsia, is not anymore, but still these patients are more likely to have airway edema, which will, of course, make difficult intubation more common. In terms of cardiovascular changes, it's a disease of vasoconstriction, so we have an increased SVR. These patients also usually have a decreased circulating volume, so they're often intravascularly depleted. They do have an increased sensitivity to vasopressors, so if you're going to start giving a bolus of ephedrine or phenylephrine, you should probably start with a lower dose than you would with a normotensive pregnant woman. Most of these patients do have an increase in cardiac output. I mentioned that one of the criteria for severe preeclampsia is pulmonary edema, and this is usually caused by a combination of the increased SVR, leaky capillaries, and fluid overload. It's only a very small minority of women with severe preeclampsia who actually have a component of left ventricular dysfunction. In terms of the CNS, most commonly we think about our seizures, but also be aware, and this is one of the causes of mortality associated with preeclampsia, is that with severe hypertension you can see cerebral hemorrhage, or you can also see cerebral edema. And so that's to be aware of. In terms of renal, we're generally looking clinically for the development of oliguria, as well as looking at laboratory values as a result of the decreased GFR that occurs in these patients. In terms of hepatic, most commonly increased liver enzymes, but in very severe cases you can actually develop a subcapsular hematoma, and that probably is the etiology for the right upper quadrant pain that some patients develop with preeclampsia, and rarely, and I've seen this myself or heard of this once, an actual hepatic rupture. Hematologically, what we worry about most commonly is thrombocytopenia. That is what's important to us primarily clinically. But also, keep in mind that in the preeclamptic patient, there is as we mentioned before, in pregnancy you get a rightward shift of your oxyhemoglobin dissociation curve. In preeclampsia, it shifts back to the left, back to what would be considered normal in a non-pregnant patient. So the P50 is actually going to be lower in a preeclamptic patient than a non-preeclamptic patient. And then the fetus and the placenta are, of course, also affected. So a significant component of preeclampsia is decreased uteroplacental perfusion, which can lead to fetal hypoxia, fetal acidosis, more likely to require emergent cesarean delivery for abnormal fetal status. You can also see these babies develop intrauterine growth restriction. So that's kind of a quick overview, all the pathophysiology and the symptoms that are the systems that are involved. So now we have a woman that presents to L&D. She's at 27 weeks gestation. She's got a headache. They take her blood pressure. It's 185 over 115. Her heart rate's 74. On urinalysis, she has 4+ protein. So she has preeclampsia. It sounds like, preeclampsia with generally, you'd need another blood pressure, but probably, she's got the headache, so severe features. So which of the following is the best medication to treat her hypertension? Anyone? B, labetalol, correct. So magnesium sulfate we'll talk about is used in the treatment of patients with severe preeclampsia, but it should not be considered a treatment for the hypertension. It will cause some transient vasodilation, but it's not going to give you long-term blood pressure control. Esmolol, we would generally avoid, if possible, pure beta blockers, as we talked about in one of the earlier sessions. And lisinopril, ACE inhibitors are relatively contraindicated in pregnancy because it can lead to fetal renal failure, and then as a result of that, oligohydramnios, which long-term oligohydramnios can lead to several other problems within the fetus. So your drug of choice. And labetalol and hydralazine are the two most commonly used medications to treat hypertension in the patients with preeclampsia. In terms of how the OB patients are going to treat these patients, the definitive treatment of the disease is delivery. However, if you have a very preterm baby, and mom is stable, they will oftentimes, definitely get time for steroids to be given for lung maturation. But if mom is stable, and it's a very preterm baby, they will oftentimes allow mom just to be watched carefully and hold off on delivery in order to increase the chances of a good outcome for the baby. Magnesium sulfate is used for seizure prophylaxis, and it used to be pretty much any patient in labor with preeclampsia was on MAG. Now practices have changed, and it's really generally just the patients with severe features who are going to be on magnesium sulfate generally during their labor. So which statement about the effects of administering magnesium sulfate to a patient with preeclampsia is most likely true? And this is a topic they do like to cover on the ITE, is effects of magnesium sulfate as it relates to us as anesthesiologists. So what would you say is the answer? So really the answer is going to be B. For a single dose of succinylcholine for intubation, that's not going to be significantly affected. You should not decrease your succinylcholine dose in a patient who's on magnesium sulfate. In terms of the non-depolarized muscle relaxants, the sensitivity is actually going to be increased. Risk for postpartum uterine atony is either unchanged or potentially increased. And although when people started using more nifedipine in pregnant patients, there was concern about combining magnesium and a calcium channel blocker. The studies now suggest that that is safe and you're not going to see any sort of profound hypotension with that combination. So in terms of the effects of magnesium therapy, therapeutic range for the preeclamptic patient is generally going to be 4 to 6 milliequivalents per liter. Things to remember is that you can start seeing some EKG changes within that therapeutic range actually, and a little bit higher, 5 to 10, including a prolonged PR interval, widened QRS. The way that the nurses and the obstetricians usually determine whether or not the patient is getting mag toxic is by checking for deep tendon reflexes. So if you lose or have significantly decreased deep tendon reflexes, you're up to a level of about 10. You're going to start to either turn off or turn down the mag at that point because you're getting into levels that you really don't want to be at. And then when you get even higher, up to 15, you can see respiratory depression, respiratory arrest, further cardiac changes, and ultimately up at a level of about 25, you can actually see cardiac arrest. So just be aware of these signs of magnesium toxicity. With actually the most common etiology of magnesium toxicity in these patients is iatrogenic, that someone programmed the pump wrong. But if you have someone with severe preeclampsia that's become oliguric, you can see an accumulation of your mag level just as a result of that. So keep that in mind. What are the effects of magnesium sulfate? Well, we're doing it primarily for seizure prophylaxis, but we do know that there are effects that are important for us to know. First of all, it can be beneficial to the fetus. It's been shown that it can increase uterine blood flow, can decrease uterine tone, though. In the past, magnesium had been used as a tocolytic agent. So in someone who's now delivering, we do worry some about potential for uterine atony with a high magnesium level. For us as anesthesiologists, we're very interested in the effects on the neuromuscular function, and it does decrease acetylcholine release. It also decreases the motor end plate sensitivity to acetylcholine. So as a result, there's an increased sensitivity to your non-depolarizing muscle relaxants. If you were to use succinylcholine long term, you would also see an increased sensitivity, but generally we no longer do anything other than give a single dose for intubation, and that's not going to be clinically affected. As I mentioned, we don't feel that there's a significant risk of hypotension when we combine magnesium with calcium channel blockers. Be aware, though, that magnesium can cross the placenta, and so you can see some neonatal respiratory depression or poor muscle tone in the baby, especially if mom had a higher mag level than what you were actually aiming towards. In terms of the anesthetic management of the patient with preeclampsia, labor analgesia is beneficial for these women like anyone else. First of all, if they're not having a lot of pain, that may help with blood pressure control. Decreases maternal catecholamine levels as a result of pain relief, which helps with blood pressure control. Also, you can, Doppler studies have shown that it can actually improve your uterine placental perfusion. But to me, probably one of the most important reasons to have labor epidural analgesia in these patients is that I know these patients are at higher risk for emergency cesarean delivery, and if I have a functioning epidural, I can avoid general anesthesia in these patients, which is even more problematic than in just the plain old pregnant woman, because we're worried about airway edema, making it even potentially more difficult to intubate, but also we're worried about sharp rises in blood pressure on induction, which, especially if you're a thrombocytopenic patient, you worry about cerebral hemorrhage. We do need to be aware, though, that if we do see hypotension develop with the sympathectomy that we produce, that this baby has less reserve, and so we're more likely to see abnormal fetal tracing. So we want to be aggressive about treating that if that happens. So you have a patient with severe preeclampsia who's requiring a C-section due to breech presentation. Her fetal heart rate is normal, so this is not emergent. Platelet count's 89,000. Yesterday it was 92,000. Blood pressure is 152/93, so not within the severe range. So which statement about her anesthetic management is most likely true? So the answer would actually be C, that actually the risk of spinal-induced hypotension has been shown to be less in women who are hypertensive compared to those who are normotensive. As I mentioned in terms of for C-section, so an epidural, as I said, if it's in place, it's a good thing to use. You avoid the risk of general anesthesia. Also, compared to a spinal, in the past, people talked about the advantage of that. You can slowly raise the level, avoid rapid hemodynamic changes. And studies have shown you see less hypotension when you use the epidural as compared to a spinal. However, spinal anesthesia, back when I was training, I was taught, especially in a severe preeclamptic, you don't use a spinal because you can get major hypotension and you won't be able to treat it effectively. That's been shown to not be the case. And so spinal anesthesia is another good option in these patients. And as I said, they're actually less likely to develop hypotension than your normal non-preeclamptic patient. In terms of anesthesia, though, there are times when you will need to do general anesthesia in these patients, and that's going to be those who have a significant thrombocytopenia. It's really a risk-benefit ratio in terms of how low you will go before you will do regional. But if the platelet count is too low, you're going to do general. Or if you have, severe fetal distress, fetal bradycardia, where you need to deliver this baby right away and you don't have an epidural in place. Things to keep in mind is you want to carefully assess the airway, have, backup plans in case you have difficulty. If it's not emergent, it may be helpful to have an arterial line to help with management of avoiding those bumps and blood pressure that you worry about in terms of cerebral bleed. So you may want to actually pre-treat this patient with some labetalol or esmolol or an opioid like romifentanil to prevent hypertension with laryngoscopy. In severe preeclamptics, I like to have some sort of infusion at least available in the room should I need it for controlling blood pressure. And as I mentioned, you're going to use the normal dose of succinylcholine, but if you want to use a non-depolarizer during the rest of the case, I would tell you you need to reduce those doses in order to take care of the fact that you have increased sensitivity in pregnancy. So I would normally, if I was going to give some rocuronium after intubation, I'd probably use half of what I would initially use in a normal patient and then use my nerve stimulator to determine how to further manage that. So now we'll go on to the bleeding protruent, a whole list of all the various options, all the various problems that we see in terms of bleeding. So you have a 19-year-old woman. She's at 33 weeks gestation. She's presented to labor and delivery with vaginal bleeding and abdominal pain. Looks like on the uterine monitor that she's having tetanic contractions. So what is your most likely diagnosis? Anyone? It's going to be placental abruption. This is really classic. Bleeding, pain, uterine hypertonus is the classic presentation. So placenta previa, that is where the placenta lies over the cervical os. These patients can also have vaginal bleeding, but generally it is painless, although in about 10% of cases you will have an abruption in conjunction with a previa. With a placenta previa, unless it's a marginal previa, absolutely you're going to need to deliver via cesarean delivery. In these patients, really, generally your management is like any other patient that you're concerned about major bleeding. Good IV access, a type and cross rather than a type and screen probably. And then in terms of choosing your anesthetic technique, if the patient is severely hemorrhaging, she's hemodynamically unstable, or the baby is in distress, you would use a general anesthetic, and you would use a drug that's going to maintain hemodynamic stability. So a hemorrhaging previa or abruption, you probably don't want to use propofol. You might want to use etomidate or potentially ketamine for induction of general anesthesia. But if the patient is having just mild to moderate bleeding, the baby's looking fine, she's hemodynamically stable, or she's come in, she's not bleeding right now, she's just having her scheduled C-section for her placenta previa, absolutely regional anesthesia is an appropriate and good choice. In terms of an abruption, this is where it's a normally implanted placenta usually, but it is separating from the uterine wall prematurely. And so, as I mentioned, you can see abdominal pain. Usually we'll see vaginal bleeding, but as opposed to a previa where you'll always see the bleeding, in about 15% of women, they develop actually a retroplacental hematoma. You don't see vaginal bleeding. So we tend to sometimes not resuscitate these patients as well because we underestimate their blood loss. You can see increased uterine tone, as I mentioned. And then because of that separation of the placenta, you're having decreased oxygen delivery to the fetus. So compared to a placenta previa, with an abruption, you're much more likely to see signs of fetal distress, and you actually may have some patients who have like a major abruption where they may actually present with a fetal demise already. One thing to remember is that the most common cause of DIC in pregnancy is placental abruption. So in a severe abruption, be aware that you should expect to probably see a coagulation abnormality. Again, pretty much your management is similar to previa. If it's a mild or moderate abruption, oftentimes these patients will deliver vaginally, just have good IV access, still have a type and cross. If coags have been normal recently, there's no reason, as long as mom's stable, to avoid doing epidural analgesia. If it's a severe abruption, usually it's going to be an emergency C-section, either because mom is hemorrhaging or baby's not doing well. Again, access, blood available. Usually these cases will need to be a general anesthetic, either because mom or baby's unstable, or it's happened just now. You have no idea what her coagulation status is because you don't have coags back yet. And so you're going to do a general anesthetic. One thing to keep in mind in this case, where usually you'll have increased uterine tone, is your drug of choice for intubation induction is going to be etomidate. You probably want to avoid ketamine, since in induction doses it could increase uterine tone, which would just make the situation even worse. Now, what is the most common sign of uterine rupture in a patient who's attempting a labor after C-section? This has been on the test in the past. So the answer is actually fetal bradycardia. That is the most common presenting sign of uterine rupture. So in terms of uterine rupture, it's going to be increased in patients who have either a prior cesarean delivery or any sort of other uterine scar, such as a myomectomy. The type of uterine scar makes a difference. If it's a low transverse prior C-section, their risk of rupture is significantly lower, and they are oftentimes allowed to attempt a trial of labor after C-section. However, if they have a vertical uterine scar that goes beyond that lower transverse uterine segment, the risk of rupture is significantly higher, and those patients are mandated to have cesarean deliveries in the future. So in terms of signs and symptoms, as I said, fetal bradycardia, you can, though, see vaginal bleeding, you can see abdominal pain, maternal instability, and also the presenting part, if the baby had descended down in the pelvis and now it's kind of popped back up, that would be another sign of uterine rupture. Again, for the most part, management's going to be like your other bleeding situations, but also realize that you may have to, even if you can do it under regional, if mom is stable, this is going to be a more complicated surgery where they have to either repair the uterus, or if they can't repair, do a hysterectomy. And so in that case, you may have to convert to general anesthesia for patient's comfort. But if it's a catastrophic rupture, where uterine contents are out in the abdomen, you've probably seen fetal bradycardia, and you're going to be doing a general anesthetic. Sometimes, though, you'll have just a uterine dehiscence where contents have not come out into the uterus. Mom is stable, baby stable. Those cases can be done under regional anesthesia. You have a gravida-4 pair, 3 women with a placenta previa who presents for C-section. Hasn't had any recent bleeding. Blood pressure's normal, heart rate's normal, crit's pretty normal. She's had 3 prior C-sections. So what is the most appropriate management for this patient who's coming for her C-section? So the answer is actually going to be preparing for a massive transfusion, because current placenta previa with prior C-section is a red flag for abnormal placentation, placenta accreta, increta, percreta, which can result in need for hysterectomy, major bleeding. So that's why you would prepare for massive transfusion. Getting a fibrinogen, you can see decreases in fibrinogen when pregnant women are bleeding, but she's not bleeding, so that's not going to be an issue yet. This is going to be a longer case where you may see some major bleeding with hemodynamic instability, so you probably don't want to do a single-shot spinal. You can use intraoperative blood salvage during a cesarean delivery, but you don't do that until after the baby's delivered, so you're not worried about amniotic fluid being intermixed with the blood, so you wouldn't use it throughout surgery. You'd only do it after delivery. So placenta accreta, it's when the placenta is abnormally adherent to the myometrium. And the problem is if you try to separate the placenta, you can get massive hemorrhage. And so usually what the obstetricians are going to do, they're not going to try to separate that placenta. Instead, they're going to proceed after delivery to a hysterectomy. And a gravid hysterectomy is a much bloodier operation than just a standard benign GYN hysterectomy. So these cases require, major IV access, aggressive fluid and blood replacement, usually arterial line in place, possibly central line. Now, let's move on to uterine atony. That is the most common cause of postpartum hemorrhage. There are many risk factors. Many of the common ones are listed here. The reality is, though, that although patients with these risk factors are at higher risk for postpartum hemorrhage, the majority of women who develop uterine atony do not have any of those risk factors. So anyone on your labor and delivery floor can develop postpartum uterine atony. So you have a woman who's a gravid of 5, para 5, history of asthma. She's developed postpartum hemorrhage due to uterine atony. Blood loss has been 500 cc's. It's continuing to bleed some. The nurse has tried uterine massage, has not helped, still have uterine atony. Blood pressure is elevated at 160/95. Heart rate is 95. What is the most appropriate initial management of this patient's uterine atony? So what's your first line drug for uterine atony? Oxytocin, which is going to be B. You have a healthy parturient who inadvertently received an IV bolus of 20 units of oxytocin. You were being fancy like Dr. Geiser likes to do, a 3-unit little bolus, but you pushed too much and you gave 20 units. So what's the most likely adverse effect? It's going to be C, hypotension. So looking at the pharmacologic treatment of uterine atony. So oxytocin is your first line drug. Things to keep in mind is that it does cause vasodilation. So as a bolus of 5 units or more, you can see hypotension. Methergin is oftentimes your second line agent if oxytocin has not been sufficient for treating the uterine atony. It is administered IM because given IV it can cause severe vasoconstriction. Its primary problem is hypertension, so it's relatively contraindicated in patients who have hypertension, be it preeclampsia or chronic hypertension. And then another second line drug is Hemobate, which is a synthetic prostaglandin. It most commonly will cause adverse effect is bronchospasm, so it's pretty much contraindicated in patients with asthma. You can occasionally see hypertension with this also, but if you had a hypertensive patient, you would choose Hemobate over Methergin. If you had an asthmatic patient, you would choose Methergin over Hemobate if you needed a second-line drug. But uterine atony, again, obviously fluid blood resuscitation, good IV access. Other things that you will see the obstetricians doing is putting in a Bakri balloon, which acts as a tamponade. Or you may have to provide general anesthesia for some sort of invasive procedure to manage the uterine atony, going from a B-Lynch compression suture to uterine artery ligation, all the way to hysterectomy. Patient may also undergo embolization in the radiology suite. One thing to keep in mind after the large study that came out in the Lancet just a year or two ago is that you should consider the use of tranexamic acid in any case of postpartum hemorrhage where all your usual treatment has been unsuccessful. So think about that, and here at UK we actually do have that in our Pyxis up on OB. So moving on to amniotic fluid embolism. This is a rare complication, but it is often fatal with mortality rates that can be as high as 80%. To have an amniotic fluid embolism, there's two things that you need. You need to have ruptured membranes, so you're not going to see AFE if the mom's membranes are still intact, and you need to have a site of entry for the amniotic fluid to get into the maternal circulation. But in a laboring patient, there's all sorts of places where there's a site of entry for AFE. You have little lacerations, little tears, whatever. So the signs and symptoms of AFE, all of a sudden shorter breath, drop in oxygen saturation, all of a sudden hypotensive cardiovascular collapse. Those are the things that you see initially. If they survive that first hour or so, then over the next few hours, they can also develop left ventricular failure. And relatively quickly, within that first hour, you will oftentimes see these patients develop DIC. The pathophysiology, we talk about it being an embolism. It doesn't really work like a mechanical embolism, though. What really happens is it's more like an allergic reaction. Amniotic fluid gets into the pulmonary circulation. You get an intense vasospasm, and then that leads to decreased left ventricular output, hypotension, and then you also, as a result of that vasospasm in the pulmonary circulation, get sudden pulmonary hypertension leading to right-sided failure. You get a derangement in your ventilation perfusion ratio, so they become hypoxemic, and you develop, ischemia at the level of the organs. About 40% of women will develop DIC, and also on top of everything else that's going on, these patients have a higher risk of uterine atony. So it's a mess to deal with, and it's really, the treatment is supportive. You're generally going to need to intubate and ventilate these patients because they're hypoxemic, rapid and aggressive resuscitation, both fluid and blood, but also inotropic support. You need to be usually getting invasive monitors in, treating DIC. That's what you do. Now, we're going to pretty much end with cardiac disease. So you have a woman with mitral stenosis, develops hypotension following induction of epidural anesthesia for C-section. Which of the following is the best drug to treat her hypotension? So think about what you want with a stenotic lesion. You probably don't want a stenotic lesion for the patient to be tachycardic, so you're going to want a drug that doesn't do that. So of your four choices here, phenylephrine is going to be your choice. So things to keep in mind, and this is the same whether they're pregnant or not, with these various valvular lesions. So if you have mitral stenosis, what do you want? You want a relatively slow heart rate. You definitely want sinus rhythm. So if you're a patient with a stenotic lesion who goes into a fib flutter, this is someone that probably is going to need to be cardioverted. You need to aggressively treat that. You need to maintain venous return and maintain an adequate SVR, and you need to avoid anything that's going to lead to increases in pulmonary vascular resistance. Mitral regurg is it's different. Now, I will tell you, because of the physiologic changes of pregnancy, pregnant women do better with regurgitant lesions than they do with stenotic lesions. So the reason being that for a regurgitant lesion, you want a normal to slightly increased heart rate. And if you think about physiologic changes of pregnancy, you see a slightly increase in heart rate. You want to, again, maintain sinus rhythm. You want to prevent increases in SVR and central vascular volume. You want to maintain venous return, and you want to avoid situations that increase pulmonary vascular resistance, but actually a small decrease in afterload can help with forward flow. So epidural analgesia done carefully can actually be advantageous in these patients. In terms of aortic stenosis, similar to mitral stenosis, that you want a normal to normal heart rate, sinus rhythm. You don't want them tachycardic. You need to maintain adequate intravascular volume and venous return. If you're doing any sort of anesthetic, you want to avoid drugs that are going to cause myocardial depression. So those are sort of your goals there. With mitral regurg, again, just like with aortic regurg, similar to mitral regurg, you want to maintain a normal to slightly increased heart rate, prevent increases in SVR, but again, also avoid myocardial depression under general anesthesia. So those are some of the basic concepts there. We could spend a whole lot more time just talking about each of those individually and specific ways to manage it. Like I said, with the regurgitant lesions, using an epidural where you can get some decreased SVR, help with forward flow can be beneficial, but you want to do it carefully. If you have someone with severe regurgitant lesions, you probably would not want to do a single shot spinal. For stenotic lesions, it's a little bit more controversial about neuraxial because of the concerns about seeing significant drops in your afterload in these patients. But most OB anesthesiologists would say that with careful monitoring and slow dosing of an epidural, you can safely do epidural anesthesia. you would absolutely be wrong if you answered that you would do a single shot spinal in a patient with aortic stenosis. Absolutely, you're not going to do. You don't want to do a spinal where you get a rapid drop in SVR in a patient with a stenotic lesion. So now, moving on to other cardiac disorders. Cardiac dysrhythmias in pregnancy. Women have a higher risk of cardiac dysrhythmias when they're pregnant as compared to when they're non-pregnant, with the most common dysrhythmia, not surprisingly, being SVT. Most antiarrhythmic drugs can be safely used in pregnancy, including adenosine. Since we're talking about SVT being most common, that might be one of the more common drugs you would think about using. You can use adenosine in a pregnant woman. One drug to avoid in the pregnant woman, amiodarone, has been associated with adverse fetal effects. So you would only use amiodarone in a pregnant patient if you had some sort of threatening dysrhythmia that was refractory to other treatment. I'm not saying you would never use it, because of course, like in an arrest situation, you may use it, but it wouldn't be your first drug of choice in a pregnant patient due to those adverse fetal effects. Cardioversion is safe in pregnancy. You're going to use the same energy levels as you would in a non-pregnant patient. The current reaching the fetus is really minimal, so you don't really worry about that. There have been some reports of transient fetal heart rate abnormalities during cardioversions. So it would generally, if you're going to cardiovert a pregnant patient, it would be recommended to do fetal heart rate monitoring. But generally, it's not like you're going to have sustained fetal heart rate abnormalities that's going to lead you to have to do an emergent delivery. In terms of congenital heart disease, this is now the most common form of heart disease that we're seeing in parturients. It used to be the valvular disorders, mostly because, first of all, women with congenital heart disease weren't making it to the point that they were, of childbearing age and well enough to get pregnant. And secondly, we saw a lot more rheumatic heart disease many, many years ago. But it is now the most common form of heart disease in parturients. And so it can be relatively complicated. You need to understand that even those patients who have had surgical repair, generally, congenital heart repairs, they don't get the heart back to totally normal. They get them back to where, they can do well. But it's not back to normal. And the cardiovascular changes of pregnancy are a stress to these patients, and you can have exacerbation. The patients can deteriorate during pregnancy due to those cardiovascular changes, even if they've had a good surgical repair. Each patient's going to be different depending on what their problem is. We could spend more than an hour talking about all the different congenital heart problems in each pregnant patient. So essentially you need to get an interdisciplinary approach where you get your cardiologist on board, your anesthesiologist, your obstetrician, and have a good understanding of this patient's particular pathophysiology and anatomy, and develop your anesthetic plan from there, keeping in mind how your physiologic changes of pregnancy are going to interact with that congenital heart disease. Now, pulmonary hypertension in pregnancy. So which statement about pulmonary hypertension in pregnancy is most likely true? And the answer is going to be inhaled nitric oxide can be used safely during labor and delivery. You can use an epidural carefully. Generally, with any of your cardiac diseases, in pregnancy, the teaching about mode of delivery is that mode of delivery should be determined by obstetric reasons. Unless someone is currently hemodynamically unstable, just because they have a particular cardiac lesion does not mean they should be delivered by cesarean delivery. In fact, you're generally going to see more hemodynamic changes with a cesarean delivery than a vaginal delivery. And actually, maternal mortality does differ between primary and secondary pulmonary hypertension. And usually it is going to be higher with secondary pulmonary hypertension, up to 60%, whereas about 30%. So this combination, though, if you're on the labor floor, you don't like seeing on the board that someone's got pulmonary hypertension, because they do not do well in pregnancy. As I said, vaginal delivery is usually going to be preferred unless there's an obstetric reason to do a C-section. These patients do need invasive monitoring, labor analgesia to prevent them from getting, tachycardic, increased catecholamine levels, and increasing their pulmonary pressures even further. Pulmonary vasodilators have been used in pregnancy, including with nitric oxide. Just be aware that if you're using really high concentrations for a period of time, there is a potential concern about fetal methemoglobinemia, but that would not be a reason to avoid using some nitric oxide if the patient needs it. Actually, the most common time that these patients have problems, though, are in that postpartum period. So if you've put invasive monitors in, this is not a patient that you're quick to get those lines out, because most commonly these patients die after delivery due to either right ventricular failure, dysrhythmias, or also they have a higher risk of pulmonary embolism.
Would you do those invasive monitors even for vaginal delivery?
Yes. This is the type of patient that you probably here our labor and delivery nurses really don't have ICU training. They are ACLS trained, but they don't have ICU training. So usually what will happen is that they will get an ICU nurse to come to labor and delivery and be with that patient along with the labor and delivery nurse. Rarely we've actually had patients where we've had a labor and delivery nurse in the ICU and had the delivery in the ICU. So yes, you would need those monitors even for vaginal delivery. And then last, cardiac arrest in pregnancy. Things to remember is that you follow the usual ACLS protocols. Baby's not going to do well if mom's arresting, so you don't worry about this drug or that drug and how it's going to affect baby. You do your usual ACLS. Things that are special, though, about cardiac arrest in pregnancy are that you need to maintain left uterine displacement. How you do that, though, is not that you tilt the bed a lot, because your CPR, your chest compressions, are not as effective in that tilt position. So what you should do is a member of your arrest team should be manually standing there and manually providing left uterine displacement so that you can still do adequate chest compressions with the patient supine, but have that uterus off of those major vessels. So that is one component of cardiac arrest in pregnancy that's different. The other is that if you have a viable baby, it's been shown that just getting the baby delivered, relieving that aortic cable compression, helps with resuscitation. So if you deliver baby quickly, it helps with mom. Obviously, it's going to help with baby. And so the teaching is that after 4 minutes of ACLS, if you have not had return of maternal circulation, then you should be proceeding now to cesarean delivery with the goal of having that baby out within 5 minutes. And so that means you don't move the patient to the operating room. If the patient arrests in the labor room, they grab a tray and they do a stat/C-section in the labor room, in the ER, wherever this cardiac arrest has occurred. You don't move the patient. That just delays things. And as I said, obviously baby's going to be doing better, but mom too. And there have been case reports of where they've done ACLS for a while, then they get the baby delivered, and then all of a sudden mom comes back. Even when it was more than 5 minutes, it may have been 15, 20 minutes they've been doing ACLS, deliver baby, and now mom comes back. So those are the things to keep in mind. Do everything the same as a non-pregnant patient, except that you have someone who's manually displacing that gravid uterus, and you're thinking about getting that baby delivered within 5 minutes. So I guess this was another key word I was supposed to include: management intrapartum fever. Treatments to lower maternal temperature, identify the cause of fever. Management's really going to be based on the etiology. If it's chorioamnionitis, they're going to get antibiotic therapy. If you think it's an epidural-related fever, you're not going to give antibiotics. There's really no treatment other than bringing down maternal temperature. And then antiphospholipid syndrome, this has been a question, I guess. This is a prothrombotic disorder with the presence of anticardiolipin antibody or lupus anticoagulant. These patients are at much higher risk for both venous and arterial thrombosis, with about 25% of those events occurring during pregnancy. So these patients are usually going to be on anticoagulation. They have an increased risk of fetal loss, especially during the second and third trimester. The thing to keep in mind, though, is that you can, as a lab artifact, have a prolonged PTT in these patients. That does not preclude giving neuraxial anesthesia. And in fact, most of these patients, you may be precluded from giving neuraxial anesthesia if they've been on therapeutic anticoagulation, because they're actually going to be on that. You follow the usual rules about anticoagulation in terms of doing neuraxial.